Today we will talk about the subfertility or infertility. Infertility is defined as failure to conceive for more than 1 year or 12 months in spite of living together and having regular unprotected sexual intercourse. And the infertility is divided into two types: primary infertility and secondary infertility. Primary infertility is when the female has never conceived before, is never pregnant before, and secondary infertility, the female has conceived before, but now she is unable to get pregnant. And there is a term known as the fecundability. So fecundability is the likelihood of conceiving within one menstrual cycle, and it occurs in about 18 to 20% of the young healthy couple, and the percentage of conception is 70% in 6 months, 80% within 12 months or 1 year, and 90% within 24 months. Next is the risk factors, or the factors which affect the fertility. First one is the maternal age. So it is the single most important factor in advancing maternal age, may causes infertility. Next is the paternal age, or the male age. It also affect the fertility. And next is the frequency of intercourse. So the increasing frequency of intercourse, they increase the chances of conception. And the maximum efficacy is when the intercourse occur on every alternate day. And similarly, the timing of intercourse, they also affect the fertility. And there are increasing chances of conception when the intercourse occur during the pre-ovulatory periods. And the other factors like smoking, stress, alcohol consumption, caffeine consumption, and the abnormal BMI, they also affect the fertility and may causes infertility. Next is the causes of the female infertility. So the female infertility may be caused by the disorder of ovulation, impairment in the oocyte production. There may be fallopian tube dysfunction, or there may be disorder of the implantation occur. The first one in the female infertility is the disorder of ovulation. So these are the abnormalities that causes a defect in the hypothalamic pituitary ovarian axis, and may causes anovulation, which can lead to the infertility. Normally, hypothalamus they releases GNRH, which act on the anterior pituitary to produce FSH and LH, and these in turn act on the ovary to release OVA or the ovum. So the causes of anovulation include polycystic ovarian syndrome, which is the most common cause of anovulation. The other causes include hyperprolactinoma, hypogonadism, or normogonadotropic hypogonadism, or hypergonadotropic hypogonadism. And similarly, the thyroid disorders like hypothyroidism or hyperthyroidism may causes anovulation and can lead to infertility. And similarly, the Turner syndrome, in which we have 45X chromosome, may causes infertility. Next is the diagnosis of the infertility in female. So first of all, we will take a detailed history in which we ask about both the maternal and paternal age. Similarly, we ask about the time of marriage, time since marriage. We also ask about the duration of infertility, and we also ask about the intercourse, in which we ask about the timing of intercourse and the frequency of intercourse. Similarly, we also ask about the menstrual cycle, and whether these cycles are regular or irregular. Similarly, also ask about the last menstrual period, also ask about the age of menarche, and ask whether there is any history of pelvic pain, cervical smear history, ask about the previous pregnancy, any history of ectopic pregnancy, any history of previous tubal pelvic surgery done, previous current history of sexually transmitted disease, pelvic inflammatory disease, any history of previous fertility treatment done, and general gynecological history. Next is the clinical examination. So in examination, first of all, we assess the BMI of the patient, and we also look for the signs of hyperandrogenism, that is acne, hair growth, which occur in PCOS. Similarly, we also assess the visual confrontation test to look for the visual field defects that occur in case of prolactinoma. We also look for the signs of the thyroid disease, like changes in the hair, skin, eye changes, like exophthalmos, Nebzega sign, and Jeffrey's sign that occur in hyperthyroidism. Similarly, we do pelvic examination to exclude any obvious pelvic pathology. We also do cervical smear and the chlamydia screening, for which we do the high vaginal swab and cervical swab. And investigations, initially we do the baseline investigation in which we do a CBC, RBS, and urine RE. And if the female has a history of regular cycle, we check the FSH level, LH level, and the anti-Mullerian hormone. And if female has a irregular cycle, then we do thyroid function test, in which we check the TSH, T3, and T4 level. Similarly, we also check the prolactin level. And infectious screening, we do screening for chlamydia, HIV, hepatitis B and C screening, and the most important test is the day 21 progesterone or mid-luteal progesterone level, which confirm the ovulation. Next is the anti-Mullerian hormone. So we assess the anti-Mullerian hormone because it tells us about the ovarian reserve, and it is independent of the menstrual cycle, and it is the most important biomarker of ovarian reserve. And we also do the transvaginal ultrasound because it provides the rapid assessment of the reproductive organ anatomy. Similarly, it also tells us about the ovarian morphology and the antral follicular count. And the antral follicular count is an important parameter of ovarian reserve, and it helps to predict the ovarian stimulation and assess state reproductive techniques. If the antral follicular count is less than 4, means that there is low response to ovarian stimulation, and if the antral follicular count is more than 16, it indicates high response. Next is the treatment. So for the treatment of ovulation and PCOS, we give certain drugs. The first one is clomipene citrate. Clomipene citrate is a first line agent for the ovulation and induction in PCOS who have normal fallopian tube and the semen analysis. And the mechanism of action of clomipene citrate is that it is anti-estrogenic, and it acts on the hypothalamus and the pituitary gland to release GNRH, which in turn act on the anterior pituitary to release FSH and LH, and these act on the ovaries and causes the recruitment of more follicle for the maturation. So the clomipene citrate, it stimulate hypothalamus and pituitary gland, and in turn the ovary to release more follicle. And the success rate is 70% of the patient will have ovulation, in which the 50% of the female become pregnant within 6 months. But the complication of this drug is, and it causes multiple pregnancies, so the woman should be monitored by the ultrasound to track the growth of the follicle and identify the time of ovulation to reduce the risk of the multiple pregnancy. Another drug which can be given for the ovulation induction is letrozole. And similarly, we also do laparoscopic ovarian drilling, and it is a method of ovulation induction, and its mechanism of action is unknown, but it involves the passing of electrical energy to the ovaries, which may causes the stimulation of the ovarian follicle. And it is an invasive procedure and should be upper only when there is no response to the clomipene citrate. Also treat the other causes of inovulation, like if a patient has a hypothalamic disorder, we give pulsatile gonadotropin, a GnRH analog, like that is goserelin. And for hyperprolactinoma, we give drugs like dopaminic agonists like bromocriptine or carbagolin, which decreases the prolactin secretion. And if the patient does not respond to medical treatment, then we do surgery. And for thyroid diseases, if a patient has hyperthyroidism, give the patient metamazole or carbimazole to control the TSH, T3, and T4 level. And similarly, if a patient has a hypothyroidism, we give her thyroxine. And next is the lifestyle modification. So in lifestyle modification, we advise the patient to consume healthy diet, stop smoking, and stop any offending drug, reduce alcohol consumption or stop it, and do regular exercise, attain a normal BMI, and similarly advise her to use or take folic acid supplement. The second most common cause of female infertility is tubal and the ovarian dysfunction. So the fallopian tube dysfunction may be caused by adhesions that are formed from the pelvic inflammatory disease, rupture appendix, or any previous history of peritonitis, which may cause fibrosis and causes tubal dysfunction. Similarly, endometriosis and the chlamydia infection, they may cause as tubal dysfunction. And the next one is the uterine problems. So the uterine problems include fibroids, leiomyomas, or a submucosal fibroid. They have direct impact on the implantation of the embryo and hence causes infertility. Similarly, the intramural fibroids, which are more than 5 centimeter, may causes infertility. Similarly, the endometrial scarring, that is the Asherman syndrome, and the endometrial polyp, they may be the cause of the female infertility. Next is the diagnosis of the tubal dysfunction. So, for the assessment of the fallopian tube, we do certain investigation, in which the first one is hysterosalpingogram, which is an X-ray, and it is performed during the follicular phase of the cycle, in which the os is open, and we inject a radio opaque contrast into a cervical canal, and then X-rays are taken to assess the morphology of the uterus and fallopian tube. But in this investigation, the female is exposed to the X-rays. Next is the hysterocontrastosonography. This investigation involves the injection of aqueous fluid into a cervical canal, and the ultrasound is used to assess the morphology of uterus and fallopian tube, and it avoid exposure to the X-rays. And next and most important investigation is laparoscopy. So laparoscopy is the gold standard for assessment of the tubal patency. And however, if a patient has a patent fallopian tube, it doesn't mean that the tube is functional. It may be possible that the tube is open, it is patent, but it may be non-functional. And the method of laparoscopy is, initially we create a pneumoperitoneum by injecting the carbon dioxide, and then laparoscope is inserted, and blue dye is injected into a uterine cavity. In normal test, the dye, they distend the tube and spill out into the abdominal cavity. But an abnormal test, the dye does not enter either the tube. And the last is the treatment of the fallopian tube dysfunction and the uterine problem. So, if there are adhesions in the fallopian tube, we do laparoscopic adhenolysis, and if the tube is blocked, we do tubal surgery. In case of endometriosis, we do laparoscopic coagulation and ablation. Similarly, if a patient has fibroids, we do myomectomy, and we can also do the uterine artery embolization. Similarly, in case of polyps, we do polypectomy. So it was all about the female infertility.